Good evening, ladies and gentlemen. I'd like to welcome you to the International Consortium on Manual Therapies Conference 2022, the discussion forum of the chiropractic group. Now, ICMT has supported other discussion forums, structural integration, massage therapy, physical therapy, osteopathic, and the chiropractic. Now, structural integration will also be presenting a part 2 on March 20th. So these forum are defined and have objectives which I'll address in addition to our main conference in May 2022. So please let me introduce my panelists, Dr. Linda Smith, private practice here in Clayton, Missouri. My colleague, Vincent DeBono, DC, and Vince, I should add, is a newly minted Doctor of Health Professions Education. He's also carrying the appointment of Vice President of Innovation and Research. And on top of that hat, he wears the interim Vice President of Academic Affairs. I'm Norm Kettner. I'm Dean of Research, Professor Emeritus in the Department of Radiology. Now, I'd like to recognize other colleagues who have participated in the ICMT, and those are Doctors James Cox, Dr. Julie Cox-Sid, and Dr. William Reed, DC, PhD. Bill is at the University of Alabama, Birmingham, and also working in the ICMT conference. Now, we're preparing these forum as a sort of an advertisement for our main meeting. I want to spend a few minutes before we start the chiropractic forum talking about this important, valuable consortium of manual therapies. And it is a science-based, interdisciplinary, crosses all disciplines that utilize manual therapies. And it emphasizes a high level of interaction and communication amongst the practitioners of manual therapy across all the disciplines, as well as interaction with researchers. So this is an unusual conference. I've never attended one like it in my 40 years. There will be 30 days of events and access and engagement. This is an online that will start on May 4th and extend to June 30th. Now, what is this conference? Well, it's going to focus on the fundamentals of building a productive culture for collaboration. That is really the long-term intention. Collaboration across the manual therapies regarding the science and the practice of manual therapies. So we've been divided by the leadership of this conference, and I should mention Dr. Brian Degenhart. Brian is a DO. He's chair of the conference planning committee of ICMT. He's also the director of the A.T. Still Research Institute and also vice president for research at the osteopathic institution A.T. Still. So Brian has a collaborator at a very high level as well, and that is Robert Stanley, PhD. Now, Robert is the vice chair of planning committee for the ICMT. He's professor of basic medical sciences and physiology at the U of Arizona College of Medicine in Phoenix. So both Paul and Brian have engineered this inaugural conference of the ICMT, and it's been a work in progress now for over 2 years. Now, we've been divided into working groups, teams of clinical, academic, and research professionals. And the topics have been under discussion, and I'll describe those in a moment, for over 2 years now. And we're all excited about presenting our collaborative work at the ICMT conference. So how is this so different? It's interactive. Most of the time, conferences, of course, are spent in a passive mode. And this will be different. You'll be engaged with a very novel platform that provides for interaction amongst colleagues and peers from across all the manual therapy disciplines. And this will provide for collaboration, the addition of insights into manual therapies, and we actually hope to shape the future collaboration and research in the disciplines of manual therapy. So we have an overarching goal of unifying the manual therapies. They're all unique and distinct, and we want to share the language, including the science, across these different manual therapies. And that's what the conference will provide. Now, there are two knockout keynote speakers. Let me introduce them quickly. Helene Langevin is currently the director of the NCCIH. So this is a National Institutes of Health Center for Complementary and Integrative Health. Dr. Langevin will be presenting lessons learned from and future directions for manual therapy research. She's a colleague and friend. Her career has been fascinating. She became an internist, internal medicine specialist, and then developed an interest in acupuncture. And that took her down many years of acupuncture research, some of which is pioneering and groundbreaking. And then the NIH pulled her into the director position at NCCIH. She's a great friend of manual therapy, and her research interests, as you see, are in connective tissue in chronic musculoskeletal pain, of course, a very common patient presentation, as well as the mechanisms of acupuncture, manual and movement-based therapies. So she has an interesting spectrum of scientific directions she's pursuing. Now, Arndt Nielsen is known to many in the field of pain research. He's the founder of the Sensory Motor Interaction Center, professor at the Department of Health Science and Technology at Aalborg University in Denmark, and the past president of the IASP, the largest and the most prominent and productive association for the study of pain. He'll be speaking on experience of sustained collaboration, and it underscores, of course, the ICMT's long-term objectives, why stepping outside of silos is important in science and patient care. So he has an astounding history across 30 years with a prolific publication record of over 900 papers. So a word about the objectives. So ICMT 2022 will offer the latest scientific presentations while engaging practitioners and researchers across the manual therapy spectrum in 3 topic areas, which I'll describe in a moment. So attendees can participate in small group sessions, contribute to the working group's outcomes, and prepare and discuss priorities for research and for future ICMT conferences. Now, this forum will concentrate on topic 1 and topic 2. The conference in May will be complemented by the 3rd topical area. Topic 1, Dr. Smith will be addressing defining manual therapy procedures. So she's going to talk about, she's going to talk about the procedures, definitions in routine chiropractic practice. She'll be followed by Dr. DeBono, who will engage a fascinating portrait of the physiological therapies, physiological theories, underlying the manual therapies. So he'll use a device called the Mindmap or the Mindmup, and there'll be options and potential discussion questions. Direct them to the chat, and they'll be addressed from there. Now, topic area 3 will not be presented in this meeting. My colleagues, Drs. Cox and Dr. Reed, will be working on those particular topical areas and deliver in the conference in May. What are the highlights? So we're going to show the latest research on manual therapy. The plenary speakers I have introduced, and there'll be additional oral sessions by well-recognized researchers in manual therapy. The conference promises to be interactive using a very unique platform called Gather Town, and it allows for innovative and thought-provoking breakout sessions, poster sessions, cutting-edge research in manual therapy, and the intent, again, is interprofessional collaboration with both researchers and clinicians who are practitioners. So this is the discussion forum working group on chiropractic. I mentioned that there were others, and this is designed, these forums are designed to emphasize the main conference in May and their interactive roundtable discussions. So we're going to ask you as an attendee to talk about, to contribute your input, whether it be critical or not. We're asking for that input, and because this is going to help us prepare for the conference. So this is not a one-way direction. We need your input, your viewpoints, and they will be incorporated wherever possible into the growing body that constitutes our understanding of manual therapies. So I've mentioned already that we are a group of clinicians, educators, and scientists who will collaborate to collect, compare, when appropriate, integrate information and data. So we are data-driven, but we're also clinician-driven. Dr. Degenhardt has repeatedly emphasized the voice of the clinician needs to be integrated into the operation of the science in manual therapy to promote that interprofessional communication. So manual therapy will be defined, and I'm going to introduce Dr. Smith in a moment. And Dr. DeBono will summarize physiological mechanisms for manual therapy. And that third goal, the promising research work, the gap in manual therapy research will be addressed in the actual conference, our inaugural conference in May. So let me introduce Dr. Linda Smith. She'll begin the discussion forum, the group 1 activity, describing the terms and the description of chiropractic technique. She'll be followed by Dr. DeBono. All right, thank you.
Okay, good evening, everybody. It's fun to be here and to know that all of you are logging on and are going to be thinking about these subjects. I joined this group because I am a clinician. I've been in practice for about 40 years now. And the question that I was asked is, what do I think I'm doing? Who am I and what am I doing? So over these past 2 years, I've been thinking about that question, and I very much want you all to be in the chat asking questions and contributing to this conversation. So some of this we've talked about, but I do want to say I liked some of these quotes. Dr. Degenhardt, our leader, says, "I'm captivated by the diverse ways the neuromuscular system responds to life events. How does it respond to various forms of touch?" So I'm bringing the chiropractic form of touch, which is certainly many, many different kinds of touch, and we're going to talk about that tonight. How can we make the alternative medicines that we use a first-line therapy? And this is what inspired me to be involved in this, to try to create a language that we could all understand. And being part of this with the osteopaths and the massage therapists and the structural integration people, just the process has been so interesting to see how do they think compared to how do I think. So I have really appreciated being part of this, and I invite all of you to join this conversation and bounce your thoughts against the thoughts of other professionals. I just wanted to repeat that we have chiropractic, massage therapy, osteopathy, physical therapy, and structural integration all involved in one conference. We're all touching patients. We're all working on them in different ways. We use languages that we don't often understand what each other is doing. Are we doing similar things? Are they completely different? That's what we're seeking to understand. I love this. It's always the elephant thing. I have to give David Lasandek in structural integration. He lent me his slide. It's always the elephant, that we're all the blind man and the elephant. We're all doing something to that elephant, and we think it's unique. We think we have the answer, but probably we each have a piece of that answer. And it would be nice to share those thoughts so that we can figure out and walk not quite so blindly through the process of taking care of our patients. Okay, so the first question that we asked was, who are we as a profession? What is chiropractic? And I'm just gonna get, there we go. A portal of entry, integrative health profession concerned with the biomechanical and neurophysiologic evaluation and treatment of disorders affecting the human body. Chiropractic emphasizes the inherent ability of the body to heal with the minimal use of drugs and surgery. I invite you to add to this. If you're in the chat, let me know what you think. You can also, my slide is not, okay, there we go. Sorry about that. Okay, one thing that was interesting in this process was the discussion of the chiropractor as a primary care physician. I don't think that the other professions were aware of us as being defined as primary care physicians. So that was interesting to me to help educate people that we really do have a primary responsibility to meet the health needs of individual patients. And that we do give particular attention to the biomechanical and neurophysiological body systems. So the operative point here was letting other professions know that we are indeed considered primary care physicians, which means we're a portal of entry and we're responsible for diagnosing the conditions that we see. We have that responsibility. Okay. We went on to define that we're licensed in every state. We have the right to use other procedures, modalities, myofascial work, acupuncture, but this does vary from state to state, and that we may not use drugs or surgery, and that is not part of our license, nor is it part of our philosophy, except when we refer out. What do we treat and what do we do? Primarily neuromusculoskeletal. We are responsible for differential diagnosis, structural biomechanics, and biopsychosocial evaluation. What are we doing? We use manual therapies to apply a sensory stimulus to the axial skeleton, the appendicular skeleton, and we also use soft tissue manipulation and mobilization. We use therapeutic interventions to address disorders of the neuromusculoskeletal system. Our goal is to maintain homeostasis of the central, peripheral, and autonomic nervous systems, the myofascial system, and the somatic end organ function. What disorders do we take care of? And this list is certainly not exhausted. But acute and chronic back pain, neck pain, radiculopathy, TMJ, tension headaches, extremity pain and dysfunction, joint dysfunction and soft tissue inflammation throughout the body. One thing I think that probably every chiropractor listening here tonight thinks, well, that's obvious. Of course, we take care of those. But I think that the other professions are not aware of us as people who as physicians who take care of extremity pain, hip pain, knee pain, foot pain, that we are involved in all these disorders. So helping broaden the awareness of who we are and what we take care of, I think, is very important. In general, low back and neck pain, including degenerative disc disorders, are the most common reasons that people seek our care. Okay, so what techniques do we use and how do we define those techniques? This is sort of getting into the center of what we did during this process. The first we talked about high velocity, low amplitude manipulation, including diversified, Gonstead, Atlas orthogonal. Again, anybody in the chat who would like to add any techniques that you would like to be listed here, this is a work in progress. Low force joint mobilization, such as sacro-occipital technique, craniosacral, Logan basic, and activator. So part of my job was to, and part of the job of the chiropractors involved in this process was to include these different techniques and make sure it was as comprehensive as possible. Low velocity, variable amplitude, mobilization, Cox, flexion, distraction. I'm just going to look in the chat and see if anybody has any questions. I see that someone has said, does the PCP role vary by state? In Texas, we are a portal of entry only. I think that's a great question. I'm not sure of that. I know in Missouri, I'm considered a primary care physician. Good question. McKenzie, guided movement techniques, McKenzie movement protocol, which is utilized by both chiropractors and physical therapists. And then somatovisceral techniques, such as applied kinesiology and SOT. And I would like, I've lost track of the questions where the chat is. I want to see if there are any questions in there. Oh, and now my little thing has, oh, there we go. Okay. The next thing, I'll tell you what, if people in the audience could raise their hand on the people who are there, if you could raise your hands, that would be great. Okay, HVLA described. How do we describe what we do? Again, diversified, motion palpation, Gonstead, upper cervical. At risk of boring you, I'll read a little bit of this, but again, please join me in defining this. A high velocity impulse or thrust applied to the intervertebral synovial joints over a short amplitude at or near the end of the passive or physiologic range of motion. It occurs in the paraphysiologic space. It's hypothesized that the stretching of the articular capsule to the limit of the anatomical space results in an intense stimulation of the proprioceptors. This contributes to a local relaxation effect. How is the technique performed? What are we doing? It's interesting, I just want to say, it's interesting to describe this to someone who has not gone through chiropractic school and does not know our language. And I think that's the job of this conference, is to help describe these in ways that anybody else can understand. A spinal segment is passively moved to its end range of motion. For example, extension, rotation of the cervical spine, extension of the thoracic spine. And a rapid impulse thrust is applied by the clinician to stretch the paraspinal tissues and joint capsules beyond their physiologic range of motion. An audible pop is heard, indicating joint cavitation. One of the discussions that we've had, and a really interesting subject of research, is what does that accomplish? Is it necessary? Do we need that to accomplish the job that we're trying to do? That is a very good research question and a subject of discussion. We talked and thought about soft tissue chiropractic techniques as something used to prepare the body for a spinal adjustment, address myofascial pain patterns, and promote healing soft tissue injury in the extremities. What are the clinical goals of soft tissue work? To interrupt musculoskeletal pain patterns, to increase circulation, to improve range of motion, and to improve overall function of the joint complex. What are some of the names of some of the soft tissue techniques? Another challenge of this conference or this gathering that I've been part of was to try not to use names, try to describe what we're doing. Well, that's easier said than done. And we ended up with some names and some descriptions, but we are trying to move away from naming a technique, because when you name it, it can sometimes avoid description by just using that name. So active release technique, which of course is a name, pin and stretch, reflex inhibition, stretching techniques, fascial manipulation, trigger point massage, ischemic compression, which some of you may know as NIMO. All these different ways to get at soft tissue. And I think this is one that we have in common with the osteopaths, the massage therapists, and the structural integration and physical therapy. We're all working on soft tissue, trying to do good things that are helpful to people. And I think we all share that we're trying to break up those pain patterns so they don't keep repeating themselves. We talked about instrument-assisted soft tissue techniques, such as Graston and sound-assisted soft tissue massage, basically using an instrument, a blunt instrument, across the soft tissue fibers to interrupt the, improve the flow of fluid in there, to improve the breakup scar tissue. Again, we're sort of making up what we think we do, and then the job of the research is going to be to figure it out. What are we actually doing? I'm describing one example, which is how is active release technique performed. After a soft tissue lesion is found, you draw specific contact on it to manipulate that tissue, taking it from a shortened position to a fully lengthened position, while the contact passes longitudinally across the soft tissue fibers. Whenever possible, the patient participates. That's why it's called active release. The patient participates in lengthening that lesioned soft tissue while the contact is maintained by the clinician, improving the circulation and the fluidity of that tissue. This is a specific example of using active release technique on a biceps. And I put this up here basically to say, we were trying to define exactly what we're doing in specific situations so that the other participants could understand how we are using these therapies. So holding a patient's arm in a flexed position, tractioning the lesioned aspect of the tissue. You get the idea. The patient extends the arm as far as possible while the clinician holds the joint. So Vince is going to take some of what I've said and put it into a mind map. But I'm really hoping, I don't know how many people we have out there, I'm hoping that we could have a little discussion right now. So I'm going to look in the chat here and just see if there's anything. I don't have any questions. Okay, well, I don't have any questions. So I'm going to turn it over to Vince and let him take what I've done with the getting the idea across and take this mind map where we took each technique, each area, and tried to break it down into a greater level of detail.
Jack, you do have one question in there, and I don't know if this is for you, Linda, or for Norman, but we're being asked how you want the contributions to the Google documents. Are we actively being asked to contribute to the Google documents? And if so, will these Google documents then be used to create a more comprehensive presentation for the ICMT or the conference, et cetera? I want to make sure I am contributing in the best way.
Oh, that's such a great question. I'm thinking that maybe Brian might answer that question. How would we best like to get this information?
Okay. Well, yeah, it is a perfect question. And at this stage in the game, we've been working, as Linda and Norm have mentioned, for 2.5 years in gathering information about each individual profession, and are comparing across the professions to look at how things are similar and different, as previously mentioned. Our goal with this discussion forum, as with the other professions discussion forums, is to make sure that we are representing, your individual profession as best as we can. And so in any way that you can, add some clarification, if there's things that you're seeing being overlooked, please post them in the shared document for the chiropractic profession, and they will then be reviewed and integrated into the final product for the conference. And what we'll be doing is we're going to be, for those that register for the conference a couple of weeks before the conference begins, we're going to be disseminating packets of information so you can see the full scope of the information that has been gleaned through this 2.5-year process. You have some time to think about it and kind of prepare some of your own thoughts as you look at the materials that are being given. And then we'll go into explicit details on it through our breakout sessions, both within the profession, but mostly interprofessionally, which I think you are going to be just fascinated by, because just like Linda, I have learned so much through this process. So is that clear?
I have one question, Brian. Are they going to be getting an email after this? Because I was thinking maybe we could send an email to everyone, like with the link to the Google document, so that they could contribute or something like that to make it really easy for them to participate.
We're sharing that information in the chat as we go.
Great.
And we can
Thank you.
add it to a follow-up as well.
And it's fine with me if anyone wants to contact me directly or ask me any questions. I welcome that.
All right, Linda, if your session is complete, then we'll move on to Dr. DeBono.
Well, good evening, everyone, and very glad to see some familiar old faces. It's very nice to catch up with some people. So as Norm and Linda said, I'm going to be sharing the mind map that we're trying to put into some kind of buckets what we do as a profession compared to other professions. So I think I do want to preface this by saying I have about this much space to put stuff into. So what that's representing is not the vast amount of research that's been done on chiropractic adjustments or on chiropractic soft tissue or the soft tissue approaches. It's basically an elevator speech of what we think most clinicians would convey back to their patients. So when you read some of this going, well, that's kind of old thinking, and but remember, this is how we explain stuff to the patient. This is not the research portion. This is the portion where if we had explained this to another profession or we had explained this to a patient, is basically what we're telling them from that aspect. So you can see, this is can you guys see this mind map okay? Or do it need to be zoomed in?
Looks good, Vince.
Okay. So this is the main mind map. It's big, so I'm not going to blow it all up. I'm going to get to the chiropractic one in just a second. But we have chiropractic and some of the various things. I'll go deeper into detail this. But when the final mind map is finished, after all of these talk sessions and we get all the input, we see physical therapy, again, using similar techniques to what we're using. The other thing I want to emphasize too, we focused on therapeutic forces on the body that are primarily delivered by hand and do not break the skin. So that was a consensus we came to because we can start going down the road of acupuncture, dry needling, which has a predominantly fascial effect. However, it breaks the skin. So we had to form the line somewhere. So all the techniques we're talking about are therapeutic forces on the body that are essentially transmitted by the practitioner, but does not break the integrity of the skin. Two main parts we're going to look at: the osseous approaches versus the non-osseous approaches. Okay, so let me back up a little bit. And again, this is a preview of what's coming: chiropractic, physical therapy, massage therapy, structural integration. So as we're going through this process of having these meetings with the profession too, this will be fleshed out further and further. Put that down for a second and go to this one. Okay, so this is the chiropractic mind map. And if you're not familiar with mind maps, they're made just to separate your ideas and put them into some kind of organizational structure where it's essentially putting some stuff into buckets and starting to say, this is kind of where this lives. And it was, as Brian said, this was a 2-year process, and man, this took a lot of time and effort to figure out what's included, what's not, where are we calling this, what does this fit in? Particularly in the chiropractic profession, those who are familiar with it, there's a lot of emotion and a lot of philosophy tied to certain techniques. So we have to take a little step back and go, what's the primary motion or primary expectation of this technique? And that's kind of what we went with on this. So I have to move this so I could see. Can you see that? We'll look at the osseous side first. Is this clear enough, or does it need to be zoomed in? How's it looking on your screens? Okay. So osseous joint structure, chiropractic. First one, we'll take a look at instrument assisted. The primary one in the chiropractic profession is activator, that most people are familiar with. When we look at, there was debate going back and forth. Is it a soft tissue technique or is it a joint technique? Is it a soft tissue if you ask Dr. Fuhrer, it's definitely, we're osseous. If you ask some other practitioners, it's not. So we fell on the side of osseous. That's where most of his research tends to be going towards. It really is a reflex protocol that they're looking at. When you look at that deep down, the origin of activator actually came from Logan Basic technique. It was originally called push button basic. Now push button, but Logan, and that's where I think some of the arguments came into, not arguments, some of the discussion came into, because when you look at Logan Basic, that's primarily soft tissue because of the context they're having. The response is coming through the soft tissue system. However, activator is making some direct osseous contacts. So that's where it lived over here. Again, this is a thumbnail sketch of what we're trying to do. Mobilize restricted joints, promote alignment of the spine and extremity and joints through the use of an instrument with a low force technique. So this does not deliver a great deal of force to the area. That's primarily, it's used for patients who aren't candidates for a high velocity adjustment or even a mobilization. This may come into play. There are some interesting analogs in other professions that I think when you come to the conference will find interesting when you look at instrument assisted. The main one in chiropractic, of course, is HVLA, high velocity, low amplitude thrust. Physiotherapy world, grade 5 mobilization. So this is rapid velocity, low amplitude, not going very deep, but causing a rapid force into the spine and articular, whatever joints we're going after. Again, it's thumbnail response, guys. There's a lot more behind HVLA, and there's a lot more we can talk about, but create a relaxation response in surrounding soft tissues and restoring normal joint play. Interrupt pain cycle, neural reflexes, promote CNS homeostasis. There's a lot said right there. That little paragraph says a lot. There's tons of research, and between the effect of gapping on the zygoapophyseal joints, the effect on muscle spindle fibers and the area around the joint getting done, the neurological effects, some different theories on the pain cycle. Is it going up, down, or down, up? Where is it coming from? Brain down or spine up? The neural reflexes that come with this. So the main impetus behind this is at the conference, which was the conference. Remember, the conference was originally planned on being live until the whole world fell apart with COVID here. The main impetus behind this was to generate responses and conversation about this, and to have people bring in their various views on this. Essentially to hopefully have people rethink some of their concepts or think further into theirs. There's an interesting thing. I've been in chiropractic long enough where the older I get, not that I'm getting old, but yes, I guess I am. The older I get, the more I tend to learn. And one of the things I've learned over time is to be a little more open to different ideas and be allowed to rethink what this is. I mean, if I told you a random fact like the tusk on a narwhal is actually a tooth, most people would be like, well, that's kind of cool, really interesting. I may look that up some more. If I told you that, the chiropractic adjustment does this and that's all it does, half of you are going to say, well, no, it doesn't. Well, hold on a minute, because it's a firm belief in what you believe in. So we have to be able a little more open, and that's the goal, I think, of this conference, is to really get that across the professions, the ability to rethink a little bit of where we're going, what we're thinking about. When I get to the soft tissue side, I'll talk about that even more, because there's been a tremendous amount of knowledge coming from that area. So this is HVLA thrust. Again, probably the main thing people think about when they think about chiropractic. That's one of our primary focuses in this. As chiropractors, we understand this has a profound effect on patients. It's a very powerful therapeutic tool, but it's one piece of the puzzle. So, and the other thing I do want to preface is by, we're covering the manual therapies. We're not touching on one of the bigger aspects that's coming into play, particularly with musculoskeletal pain, and that's the psychosocial aspect, which is planned for the next conference, because that's such a vast topic. But I think we have to get this piece out of the way first to understand what we're talking about when we're talking about manual therapies. Once we understand that, I think that opens a lot of pathways and a lot of doors to understanding, how do I tie my manual therapies into the psychosocial aspect, the biopsychosocial, patients' lifestyles, patients' past, all this other stuff. But I think we really need to understand this first. The other piece, moving down here. So 3 main ones: chiropractic, instrument assisted, HVLA thrust, and then mobilization. And this is a catch-all for some of the therapies that really don't deliver an HVLA thrust. They're not using an instrument. So in that category, probably the larger one in chiropractic are the directional preferences. There's 2 main areas of that. Flexion distraction, which is the use of a table to create, and a technique to create a distraction and traction force. And again, this is a thumbnail. And Dr. Cox can supply you with volumes of research on the proposed effects of what this is. But basically how it's explained most of the time to patients is to reduce disc and restore motion to the lumbar facet joint. There's a lot more to this. We all know that. But that is categorized as the flexion distraction was categorized as a directional preference technique. Flexion, the predominant motion in this technique, and the relief primarily of radicular symptoms, primarily of when we look at radicular pain on that aspect. In the same category as mechanical diagnosis and therapy, the common one in here is McKenzie technique, and the main premise behind that is the establishment of a symptom relieving direction, trying to look for what direction can I put this patient in a motion, a guided motion, to relieve pain. Their main premise is to centralize pain. Most people associate McKenzie therapy with extension. That's just one of the motions. I've had a number of patients they've responded better to flexion or lateral flexion, or even extension with lateral flexion or side glide. So there's a number of ways to figure out what position we could put them in to get pain relief. And then it moves forward from them. So this is again, debated, is this osseous or non-osseous? And we put it in the osseous categories because there is some emerging research coming out on the effect of the end plate, particularly in degenerative disc disease, becoming a pain generator. And I think there's some real research that lies in both of these techniques, both flexion distraction and MDT, that has to do with taking that pressure off the end plate to relieve some of the pain. Again, the primary goal of both of these techniques is centralization of pain. So they're really radicular approaches, coming after radicular pain and trying to get it move, make life simple, move from the foot up to the back. So centralize their pain. And again, I think there's a lot of discussion to be had here, particularly the effect of, again, the facet joint on this action. Also, I think there's tons of stuff on the it's becoming more and more commonplace now. The effect of the disc, the end plate itself, not the disc, but the end plate itself becoming a pain generator. I know Norm and I have been looking into some of the cytokine studies coming out from functional MRI units looking at the cytokine response of the disc and of the end plate. So that's where I think there's some real fun stuff to talk about in our directional preference therapies, moving away from the mechanical model of I'm trying to suck the disc back in, which we still hear, to I'm trying to create an area where I'm taking pressure off an end plate, or I'm restoring function into this facet joint, or I'm doing this aspect with these therapies. Those days of, you squeeze a jelly donut and the jelly comes out, we're trying to suck, it doesn't work. So, And then finally, mobilization, which is a general term for grade 1 through 4 mobilizations. And again, the grade 1 through 4, the reference on that, guys, really comes from the Maitland work on what the grades of mobilization are. But it's anything you're doing to the spine that's below a grade 5, which is that HVLA thrust. And these get progressively from a grade 1, which is basically stretching, to a grade 4, which is actually putting some long lever approaches into moving the areas. Remember, most HVLA thrusts are specific to a segment. Some of these mobilizations are long lever and very general. And the therapeutic effect: improve joint play, stretch soft tissue, restore normal motion. Again, it's putting stimulus into the spine, a little less specific than, less specific than the HVLA thrust for mobilization, and with less force, and with a longer amplitude. These tend to be rhythmic, longer motions, where the HVLA thrust is a short, low amplitude thrust. So those are the primary distinctions in chiropractic. And amazingly, when you boil it down, it really is 3 big buckets of where we could stick stuff into. This was probably about, and Norm and Linda could attest to this, we probably had about 30 buckets over here when we started. You know, and slowly start to realize, well, that really fits here, that really fits here, this fits here, this fits here, this fits here. So this took quite a while to get it to 3 buckets. So if any of you guys come up with a 4th bucket, you're gonna have to pay me. But no, if you think of a 4th bucket, let me know and we can certainly throw it in there. Any questions or anything? Anybody want to raise their hand on this osseous side, or? Oh, can't see hands raised, so.
I
Good.
don't see any hands up.
Okay, perfect. Okay, now the non-osseous structures. This is
We got
soft
one. We got one raising his hand.
tissue. All right. What am I doing?
Thank you. Having listened to Vincent and Dr. Smith, I'm struck that we should go back in Dr. Smith's description of the purposes of spinal manipulative therapy and add the word afferentation. I think we've just heard it talked about by Dr. DeBono, and because of its importance, I'd like you to consider placing it under your list of purposes of spinal manipulative therapy, Dr. Smith. I think we've called it here neural reflexes, and I think we're going to add to that the word afferentation.
I'm writing that down, Dr. Cox. Thank you.
Thank you.
And that, Dr. Cox, that's under HVLA?
No, that would be back under Dr. Smith's first presentation.
Okay.
Where she had a list. You know what I mean, Dr.
Yeah.
Smith?
Yes, I know. Yep.
Because it's going to really fit into what you were describing, Dr. DeBono, when we discussed biomechanical afferentation. Thank you.
Thanks, Dr. Cox. That's a great point. So, good. I'm going to move over to the non-osseous structures side, which is the myofascial soft tissue side.
Vince, I
And-
wonder if I could interject a question. Dr. Cox made me think about it with his question. I was trained that the concept that you could identify the so-called, in quote, specific level of manipulation. I never thought that was a realistic expectation because of the linkage of the biomechanical system. Have I mistaken that assumption? Can I mobilize a joint?
Thanks for that loaded question, Norm.
I would say as a
But it's-
practitioner, from a practitioner, I would say, no, you cannot. That it's
From-
always a multiple set of joints.
Thank you. Thank you.
From the perspective, Norm, of finding a fixation or finding something that's a bone out of place. And again, this will probably raise some hackles with people. Bones don't move by themselves. You know, they're connected to muscles, ligaments, tendons, everything else that maintains the structure and maintains the patterns within the body. The upper lower cross, the middle cross patterns, these Yonda Levitt patterns that we get put into drive what we as chiropractors sometimes where we perceive as a fixation. It's not that this bone decided to go spinous left and stuck there. What happened is the entire musculoskeletal system has a pattern that's drawing this portion of the spine to be fixed in this certain direction or perceived less motion in this certain direction. So I think when you're applying an adjustment to an area, you may think you're moving T4, you're moving the entire system. So you're putting in stimulus into the entire system. And it's something that's bothered me in chiropractic for some time, that we've gotten away from the systemic approach. We're saying, I'm adjusting this segment, it's going to affect this, it affects the whole body. There was a demonstration when I used to teach some soft tissue work. We'd pull someone up from the audience and we use a Graston tool on their low back, and we'd have them try to touch their toes. And of course they couldn't touch their toes. Then we'd put some stimulus into their low back with a Graston tool, and lo and behold, they could touch their toes. So one day I decided to get smart and give something else a try. We brought someone up, tried to have them touch their toes. They couldn't touch their toes. So then I did Graston on their bicep, just their right bicep, for about 5 minutes. Guess what they could do? Touch your toes. Because it's stimulus into the system. And I think we have to remember that. So the concept of adjusting a certain segment, I think, is for the most part antiquated. What you're really doing is what am I going after, and how am I affecting the entire system by what I'm doing? So if I'm choosing flexion distraction or I'm choosing HVLA, there are two different stimulus I'm trying to put in, and those stimulus will affect the systems in different ways. It depends on what I'm going after. I hope that answered your question. That was kind of a long-winded response to, no, you can't move one segment.
I would just like to interject something in here as a clinician, that what I want from this audience is to tell me what they think they're doing. Because that's my job as the clinician in this process, is just, even if it turns out not to be correct, that I participate by saying, I think I'm mobilizing several joints at once. I think I'm affecting the whole body. That we really want clinicians to chime in with what do they think they are doing in this process of being a chiropractor.
Right. I think that's a valid point, because one of the things we have to remember is, when I've been practicing chiropractic for 33 years now, and I remember my first 15 years in practice, I would look back on a patient and go, I have no idea how they got better. I know what I did, but geez, how did that work? And that's where you start to explore and go, well, what is this doing? So that's a great point. Tell us what you think you're doing. And there may be research back there that backs up what you're saying or refutes what you're saying. So you know what you're really doing? You're doing this.
Dr. Cox, did you want to say something?
Just a summary quickly. 15 years ago, we didn't appreciate cytokine inflammation. I heard Norm Kettner present a conference at Logan with a neurosurgeon from Harvard, and they were pointing out that they could treat carpal tunnel syndrome by treating the posterior tibialis or anterior tibialis nerve. And we will get into that, about the cytokine inflammatory changes with manipulation. We'll talk about sinovertebral nerve that supplies 2 to 3 levels from its own primary. So that when you give an adjustment, certainly we're not just treating a single segment, we're treating a big part of the sympathetic nervous system. So I think this will be a great conference, in that we will be able to bring the literature into a pretty updated status as to what happens and what has to happen in order to give a patient relief from a spinal adjustment.
I'd like to add something which I think is what makes this conference unique, which is that I have learned things about the fascia and how it works from the structural integration team and how they think about it. And I read one of the books by one of the participants. And so I just encourage all of you out there to attend this conference, not only to learn what do other chiropractors think, but what do other professionals think? What does the physical therapist think? What does the massage therapist think? And I think that that is the route to figuring these things out.
Well, allow me to echo on both of your comments. I'm most driven to develop the clear identity of the evidence gap in our profession, and hopefully in other manual therapy disciplines as well. We don't know the size of the chasm between what we think we're doing and what science is providing in terms of understanding. So the evidence gap is one of the major objectives for this conference. We need lots of discourse in order to sense the depth of that chasm. How far are we from the reality that science may illuminate? And we need clinicians to drive that particular function. So as Brian just mentioned in the chat, this is a discourse that drives us towards understanding how the evidence gap is structured. How large is it? What do we need in terms of future trajectories for research?
Okay, guys, I want to make sure we get over to some of the non-osseous pieces because I think this will simulate some discussion too, dovetailing on what we were just talking about, this system-based approach. So in chiropractic, we don't really own myofascial or soft tissue. I don't think anyone really does. It's a common domain therapy across professions: massage therapy, osteopathy, chiropractic, physical therapy. We all look at soft tissue. Now, I've been fascinated with, when I was in school, soft tissue, fascia was stuff you just peeled away so you could see the muscle on the cadaver. And that's about what we learned about it. It's like, yeah, that's just the paper in the box. It's just the wrapping material. Don't worry about it. Doesn't do anything. It's inert. Really? Then Helen Langevin came along and, David Schleip and our colleague on this conference, I can never say his name, David Lewezendak, starts with an L, but they've done phenomenal work on understanding the effect of the myofascial system on it's largest system in the body, affecting our overall health, and not just our physical health, the profound effect it could have on our mental health as well. So it's fascinating. And I remember that it was 2000, and I think the article was published in 2003 by Helene Langevin. And she ended the art, at that time, she was at the University of Vermont, and she was talking about acupuncture and the effect on loose connective tissue, how fibroblasts had cell-to-cell communication from the stimulation from an acupuncture needle. So in other words, when you stimulated using an acupuncture needle, the fibroblasts, the main cells of loose connective tissue, actually connected with each other and passed along calcium, which means it's conducting a signal. So it's the first time we saw in any cell outside of cardiac, the only other cell that does that we knew about was cardiac muscle, because cardiac muscle can do cell-to-cell communication when electrical conductivity shuts off. It's a last-ditch effort to keep the heart pumping. Well, finding this in fibroblasts changed the whole game. Now there's a separate system of communication outside the nervous system by direct stimulation of fascia and fibroblasts. So that really opened the door to, and I never forget, because the last paragraph in the article, she said, so that patient who came in with a gastric ulcer and 2 weeks later comes in with a sprained knee, you think are two separate events? May not be. So for an MD to write that in 2002 was like, what the heck? Wait a minute. You know, because we, as chiropractors, that's how we kind of thought all along. Everything is connected. This equals that, this equals that. And, you know, we have certain therapies in chiropractic that address internal disorders. And I was always kind of on the fringe of it, like, I don't know. But boy, did that change my mind. It's like, well, wait a minute, maybe there isn't a way to affect some of our internal systems through the loose connective tissue by the stimulus we're putting in. So that being said, I really started going very deep into the soft tissue, attended a lot of the fascia conferences. So this is kind of my side of the mind map that I really like to live in. But when we looked at the chiropractic techniques, we try to take the most common techniques used in chiropractic. Sure, we all use different ones, but the main just breakout, this was a discussion, do we need to break this out or not, an instrument assisted? Because really just adding a lever to get a little more force behind something. Now the original, when I originally took some of the first instrument assisted soft tissue seminars, they were probably about 15 years ago. Their theory was you're breaking adhesions and you're breaking up this. And I think in reality, that's starting to change as we understand the fascial system better. Even with cross friction. So we also put myofascial techniques, which are really the techniques we're doing by hand, and broke those out into two categories, superficial or deep. The main distinction here is what are you trying to do? So with superficial techniques, effleurage, petrissage, that's really a fluid dynamic technique. We're trying to move superficial fluid throughout the system to reduce edema. Not really looking at changing so much into what we're doing with deep tissue techniques. So I would lump in instrument assisted with our deep tissue discussion because, well, actually with both. You can do superficial with instrument assisted by doing some of the brushing techniques, but we can also do the deep tissue techniques using both. So this one I would kind of lump in with what we're talking about here. So on the deep tissue techniques, it's really focused on addressing fascial restrictions. Now the work done by the Stekos has been groundbreaking to me. The concept of densification, where we're actually changing the gliding inside of the normal fascia by changes to the hyaluronic acid and changes to those areas. So those stuck areas we feel with our soft tissue techniques. And then you'll hear this all the time, not so much in chiropractic. I've heard it more in the massage therapy realm, and even in the structural integration realm, where we get the patient to melt. Like, oh, that feels like that's melting. And actually, they're not far from the truth. So the concept of densification is if you think about a pan full of bacon grease and you left it set on the stove, that's densification. Now, if I went in and rubbed my thumb on that bacon grease, got it going, it changes, starts getting back to what bacon grease is supposed to be, liquid. Same kind of concept where we talk about hyaluron and the effects within the soft tissue, profound effect on nerve gliding and a lot of other things. So there's a lot more going on with soft tissue than the so-called breaking adhesions or busting up a trigger point. It's moved much beyond that. And I think it's really broadened our understanding how this affects us back as chiropractors from the structural point of view to the spine. You know, if I have restrictions into the spine, but I also have a lot of changes in the fascial system surrounding the spine or into an extremity, you know, we've all seen as chiropractors the so-called double crush syndrome, where they have a vertebral disc and then we kind of clear that out. We get that pain decentralized, but they still got this hanging on radiculopathy because the nerve's also entrapped at the elbow. And a lot of times we used to chase a lot, Norma, remember these days, looking for tarsal tunnel, looking for, you know, a supracondylar hook. Maybe they got some oddball thing like this. In reality, most of the time in my clinical practice, when I saw that, it simply was trapped in the fascia, and getting that released stopped that. So I think the fascial aspect can generate a lot of conversation across professions we've had some great conversations between massage therapy and structural integration on these topics. They've been some great, to start talking this stuff 7:30 on the Friday morning and get excited about it means there's really something to it. So I think this part of the conference will really be open for a lot of discussion. Even here, we also broke out these to the reflexive somatovisceral techniques that we've seen used, strain, counter strain, contact reflex analysis, where you're looking at some specific soft tissue points. Again, mechanism here, probably going through loose connective tissue that surrounds organs, end organs. So, and there, I think there's still a lot of work to be done of what the effect of loose connective tissue stimulation has on the end organ, whether that's stomach, intestine, muscle, whatever. And then finally, we looked at some guided movement pieces, for lack of better terms, proprius, PNF, which is contract, stretch, contract, stretch. So it's kind of using that stretch reflex to get more range of motion into the area. And then neuromobilization, also known as nerve flossing, nerve gliding techniques. There's a lot of names for it. Originally, the work done by, boy, the name's escaping me, Butler. The seminal work was probably done by Butler on neuromobilization. And then again, that's performing various predetermined movements or exercises that stimulate the nerve or have the nerve glide during its path. So again, I would, any input back from the audience of any major bucket we've missed on the soft tissue aspect or non-osseous aspect, I'd love to hear about. And again, be careful, guys. This non-osseous piece can also be mind-body, but that's for the next conference. So, because we've had that discussion saying, well, technically non-osseous can also include the top-down effects, the mind-body effects, but that's for the next conference. So we want to clear up all of our manual stuff. Basically, I think you'd agree, Norm, we're looking at everything below the occiput for this one. And then we can move up beyond it after the next, at the next conference. So again, this is one piece of a giant map. And as the other groups meet together and fill in their maps more and more, and we'll refine this one after this conference again, based on your feedback, I think this will be a great, great resource for chiropractors to talk across other professions and for other professions to talk across to us as well. So I welcome any questions or any comments or anything you guys want to talk about, but that's really what I got. So
It's let me pop a question here before things cool down. I've forgotten the justification for somatovisceral only on the non-osseous side. Why don't we include that on the cousin side, osseous as well?
you talking about the old Merrick system?
Yeah, the visceral, the somatoviscerals, and I think I would have modified that to somato-autonomic reflexes, somato-autonomic. But why didn't we put it on the other side as well?
Well, most of the research, and it's a good question, Norm, but most of the literature I saw, and I know we're supposed to go by practitioner, but even talking to some of the practitioners who use like applied kinesiology or contact reflex analysis, most of their techniques are not osseous, they're soft tissue. You know?
I don't know, in applied kinesiology, they'll use the muscle testing to decide where to use HVLA.
Yeah, I can't go down that path.
Well, I mean, I think that you make a point, Norm, that we could certainly put it on both sides. There's no reason it can't be on both sides.
I was looking at that's a diagnostic procedure. I was only looking at the therapeutic approaches they're using, and a lot of it's direct contact or stimulation of loose areolar tissue. That seems to be what's coming into play. The other one, that looking at the level of the spine, again, that's kind of going back to that old Merrick system piece. Now, I would make that argument, maybe that's one of the reasons I'd have to think about it more how I can in my head, because granted, an end organ dysfunction, like an end organ dysfunction in the liver, may have ramifications into the spine, but probably where that's coming from, it isn't that it's sending a nerve. The way we taught old school, sends a nerve signal back to the spine, irritates the spine, moves out of place. I don't think that's correct. I think what the current research is probably showing, that end organ irritation is probably irritating the entire myofascial system around it through the fibroblast, causing this dysfunction to come back that manifests in thoracolumbar junction or mid-thoracic spine, or depending on where that's coming back to. So while it may lead to some of that, we'd have to look at that a little bit more, and I'd have to look at the therapeutic side, but that's certainly a discussion we can have.
What about considering the embryological level of development for each organ, which is where some of the concepts that are used in AK and SOT with the visceral somatic takes into consideration?
That's a great question, Mary, and that's one I was hoping someone would come back with too. That is something we can look at as well. Again, how does it come back to the level of the I would agree with that too, the myotomes, the sclerotome piece that comes from the end organ ties back to the musculoskeletal system. I'm going to depend on your expertise more for that than for mine.
Wait, Mary, I don't quite understand. When you say you'd like to bring that up, are you saying you'd put it in the mind map in a certain place, or tell me a little more about what you're thinking?
Well, consideration of the linkage of the organ to the spine from an embryological as well as neurological point of view, because the autonomic nervous system, you know, it's from sympathetic, parasympathetic, varies through the plexuses with sympathetic, right? Sympathetic tone. But I'm wondering about that embryological link. There was a book written by Pottinger, Symptoms of Visceral Disease, MD, that I believe some of that thought process is laid out in there. I'd have to go back to that book. Dr. Cox?
Yeah, I have Pottinger and some of George Goodhart's work on somatovisceral reflexes. And because of this beautiful discussion here, I wonder, Dr. Smith, if you would mind adding to afferentation some of the work that's going to be beautifully covered by Dr. Bill Reed on the neurophysiology of spine mobilization and manipulation. So therefore, could you add the vagal anti-inflammatory reflex to afferentation? Because as this last speaker just alluded to, and Norm is certainly an authority in this.
Could you say that once more, Dr. Cox? Just say that sentence, vagal what?
Yeah, the vagal anti-inflammatory reflex. That means whether you're treating from the abdomen to stimulate the ventral vagus or the brain to treat the vagus nerve, we definitely treat somatic autonomic reflexes, which I think in the future holds great discussion and great benefits for spinal manipulation in treating our patients. So I'd like you to, if you would, with afferentation, put vagal anti-inflammatory reflex, because as the last speaker just spoke, when you're comparing sympathetic and parasympathetic, and we live in a hyper-parasympathetic society, we all need parasympathetic input. That's the vagal anti-inflammatory reflex, and probably no one knows more about that than Norm Kettner does. But I think if you add that, it opens up a new chapter for us.
I got it. Thank you.
It's a great point, Jim. We need the investigation. So far, manual therapy has limited evidence for impacting vagal responses or stimulating vagal responses. Most of the work shows sympathetic response initially. Maybe over a longer term treatment, vagal may come to dominate. So we talk about the sympatho-vagal balance. And as you've mentioned, vagal stimulation transcutaneously at the ear or at the neck has been shown effectively to trigger that anti-inflammatory reflex described by Tracy back in 12 or 13. And now I'm excited to report there are trials ongoing to treat the ARDS, the cause of death in COVID-infected respiratory disease is directly the result of pro-inflammatory cytokine. The toxic flow of cytokines can be modulated by vagal stimulation. Those trials are at least underway, so there may be another resource for managing COVID patients.
And certainly this conference, Dr. Degenhardt will tell you that the osteopath has been a leader in the study of somatovisceral problems, doming of the diaphragm, stimulation of the celiac. These are all wonderful things coming out of this conference for future discussion. Do you agree with that, Brian?
Yes, I do. Thanks, Jim.
Mary, thanks for that input too. And I'll catch up with you, Logan, on that Pottinger rep. I like to see that too, because that is a good, I forgot all about that.
If we, when in adding that in, and Mary, maybe you could say something, would you put that on the osseous side, the non-osseous side, both sides? Would you create a new link, a new side? What is your opinion?
I came in very late, sorry. So I missed the first 45 minutes. So I don't know what all I missed, but with that question, I'm thinking from my SOT techniques, which we always work with the non-osseous, well, we work with the non-osseous side, but also the osseous side. So there's a combination.
Right.
But we're always we see patterns, you know, of dysfunction. So as Dr. DeBono is talking about, you know, recognizing the patterns, it's part of the pattern which draws back to the spine. So my trainings, you know, or yes, there can be a fascial link, but you also look at the direct innervation or the air, you know, addressing the spine for the innervation and afferentation. I love that aspect, but also freeing the fascia around, working with the organs to restore some of the balance of the autonomic nervous system communications.
You know what, Mary and
So it's
Linda,
some of both.
yeah,
I think it's some.
I do recall why we put it on the non-osseous side. Now, it was a conversation I forgot we had. This was a while ago. I think what we were looking at on the osseous side is the end organ. So most of the techniques we talked about on the osseous side have, it's a direct effect to the spine for typically for spinal issues. We were looking at the reverse with the osseous component that comes from the somatic visceral reflex. Now the part's escaping me why we decided to put that over there. But it's certainly something we can look at from both aspects of that and figure out where that's going to live.
In the area where you had superficial fascia, the deep fascia, and could there be an addition of true scar tissue versus the densification? Because we know with acupuncture, scar tissue needling has a tremendous effect. And so could that be a third for that area? So superficial fascia, your densification of fascia, so more deep fascia, but then the true scar tissue.
Was true collagen or true structural changes. So collagen, yeah.
Yeah, from surgical scars, etc.
Right, because the distinction between superficial fascia and deep fascial techniques, the superficial fascia techniques typically don't affect the hyaline because the hyalin's down into the deep fascial layer where most of the stuff goes on. But scar collagen changes could be anywhere in any of those layers. So that is something we can tease out on that too, Mary.
Okay, Mary, I got that. Thank you.
Okay, I think that's it for me. And then is it back to you, Norm?
Got one hand raised.
Oh,
Oh, Gregory just pulled it back down. There he is.
Yeah, I don't want to interrupt if you have another presentation. One thing that came to mind in this, excellent presentations, and maybe Vince, you could add the ANS piece to the osseous side in that one box where you have neural reflexes listed. You could just add including ANS, and I think that might get at what was being said. But what I was wondering is in Dr. Smith's presentation, she listed the effects of manipulation, did a beautiful job on the neurologic reflex effects. And in the mind map, it did talk about restoring motion, but I think maybe I'm not sure how important it is, the listing of things. And if it's not that important, then forget I ever said it. But I think there's a direct biomechanical effect when you apply a force into a joint. You're moving the joint. Hypomobile joints do develop adhesions, so the goal can be to break up those adhesions. And so kind of a direct biomechanical effect, in addition to all the important neurologic effects that you've discussed. So perhaps just a mention of that somewhere along the line would be the
So
only.
if
I
that,
think that's a very valid point, Greg, too, particularly to your work with the zygopophyseal gapping part of this too. So yeah, I think we do have to do, that's a great point to put in the direct biomechanical effect to adding that force to that segment.
Mhm. I think in your mind map, you know, it was in there in that box in a way, but I think if in the list, if you could add it, that might be nice. Thanks. That's all.
Thanks, Greg.
what is ANS, Dr. Kramer?
Autonomic nervous system.
Oh, okay. Sorry, wasn't sure what you meant.
Okay, is this back to you, Norm?
Sorry, please. Are there any additional comments? I'm delighted to see Dr. Kramer in our audience. He's the icon in neuroanatomy. All right, well, I'll bring things to a close then. I'm delighted to have such a collaborative discussion with clinicians and educators and even scientists on board. And I'm hopeful that this experience, and if I could have the next slide, please, that this experience tonight will help propel and compel interest in the upcoming symposium. There we go. So
You're not sharing,
I see-
sharing your screen, Norm.
I don't have share control.
May I ask a question, Norm, while you're figuring that out? Or not a question, but may I make a comment?
Of course.
So I just want to reiterate to everybody here in the audience that we're so glad that you're here and that you've listened to us tonight. And I just want to reiterate how great it is to listen to other professionals talk about what kind of tissue they think they're affecting and what they think they're doing. And that to me is the most interesting part of this whole conference, is to learn about what other professions are thinking. And so I just hope that all of you will carry on and come to the conference from wherever you are in the world. You can join us. Also, Dr. K, and are you going to talk a little about GatherTown and how that works?
No, I won't. Not in this time frame, Linda.
Okay.
I suspect there'll be information coming out on that topic, and
Well, may I make one sentence then about that? That it's an interactive forum where it's not just a Zoom conference. It's much more creative and interesting than that. So the name of it is Gather Town, and Joffrey, maybe you can give them at least a link to find out about it, because it looks really fun.
All right, thank you. Well, with that, I'll close tonight's forum. I hope you found interest and utility in this kind of collaboration. We're all looking forward to the conference in May. As you can see, it's 30 days of this kind of interaction, clinical viewpoints, research work, lots of new information coming on the manual therapies. So I hope you'll join us. You can find more information on the conference at ICMTconference.org, ICMTconference.org. The full website will give you the background, our objectives and goals, and the program itself. So thank you for your participation tonight. And hopefully we'll see you at the future event on May 4th that will extend into June 3rd. Thank you again. Stay well and good night to all of you.